Okay, we're back to talk more about that shortage that we kind of talked about, we touched on just for a minute. First, introductions. First, we have with us Dr. Michael Bly from the Goldfarb School of Nursing. Also back at the table, who you just saw there, Dr. Heidi Miller, Family Care Health Centers. And Dr. Doug Pogue, back from the first part of the show, you'll recognize him. And with us tonight is James Sandler, nurse practitioner with the Downtown Urgent Care and also out in Eureka. So we talked just a little bit there about the urban core and rural, so we'll get your perspective on both of those. But I want to know, why do we have a shortage of primary care providers? Don't be shy.
There's a number of reasons. A couple things. One is, if you think back to doctor shows in the 80s and 90s, when young people are otherwise looking at TV and catching a vision for what they might want to do with their lives, nobody ever talks about primary care. It's always the dramatic stuff, right? It's ER, it's emergency surgeries, it's the heart valves, it's all the stuff that young people look at and say, wow, I want to do that someday. Prestige. The second thing is there's a big monetary problem in medicine. We think that we've got a real priority on primary care, yet we allocate all our resources to a lot of heavy specialty type of stuff. So when all of the resources are going to, hip implants and cardioverters that you implant in people's chests and other things like that, you get a medical student who's gone through medical school, they like a lot of different things that they've seen, and then they're trying to make a decision what they want to do with their lives. They say, well, I can make this amount of money doing primary care, or I can make twice doing this, or I can make 4 times as much doing something else. I mean, these are smart people to begin with, right? So they start looking at that and they say, well, I like this too, so why don't I go do this?
And have all of those specializations, and they've all paid about the same for medical school? It's not like you're paying less for medical school to be a primary care physician, correct?
Correct.
That's exactly right. And I think it's fair to say too that social demographics are really truly shifting in a way with the baby boomers going through. We're living longer. All of the technologies that have supported healthcare, actually it's illness care more than it's healthcare, but all of the specialties that have done that work up to and including the cost that we spend at the end of life, which is very dramatic in terms of where we're spending a lot of money for really, truly some feudal patients. We've got to come to rebalance that and recalibrate that. So I think there's simply more people living longer who have a lot more multiple polychronic conditions that really make the important role of the primary care provider really critical at this juncture.
I think one of the challenges is that primary care providers are being asked to do so much more with less time and less money. I was very, very lucky to know an elderly physician in his 90s, Dr. Jerry Flantz, before he died. And he spent an hour with a new patient and a half an hour with the follow-ups, and he had an incredible relationship with his patients. I am expected to see patients every 15 minutes. They are very complex. And in one appointment, I'll be expected to address the knee injection, the depression, patient's got a trigger finger, and the reimbursement for that visit, for the medical evaluation part, the reimbursement might be about $100. But if one of those 3 specialists from those 3 specialties saw the patient for one issue, their reimbursement would be more. It would be sometimes a factor of 2 to 3 times more.
So imagine the pressure on a physician or a nurse practitioner trying to do that. I'm sorry, but that's really hard work. And it takes its toll after a period of time. And I think the public is generally aware of that. And certainly nurse practitioners and physicians going into primary care, they know what they're signing up for.
And it's not good for
complicated.
Sorry to interrupt. It's not good for the patient either. I mean, it's stressful for the provider, but the patient is not getting the attention that he or she needs. With those complexities, you simply can't attend to everything. And something's going to fall through the cracks, and that might be the actual thing that's going to end up hurting that patient or cost the system more because the long-term outcome is going to be poor.
Go ahead.
So there are many studies that predict primary care shortages. However, primary care
significant,
is
like 60,000 short in the next 10 years or so.
However, medicine is changing, and we are moving toward a team-based approach. So there are actually some new studies that show that if you work in a team with your nurse practitioner, your pharmacist, with your nurse, with your medical assistant, and you distribute some of those chores, then you will be able to increase capacity and try to prevent burnout from everyone who's trying to do this race.
Absolutely.
And the healthcare world is changing. We have Obamacare, as just about everyone calls it now. How will that be a factor, and will it make it better, make it worse? Or do we know?
Well, go ahead.
I think one important thing about Obamacare that, regardless of your politic, is that for the first time we begin to redistribute some of the resources to the idea that you don't have to get sick. Most of the discussion so far this evening starts with illness as a given. But we know, and a lot of the work that nursing dedicates its science to, is to keep people in a preventively well state. We like to present ourselves in school systems. We'd like to present ourselves in other scenarios other than the sickness system where people have to come to us. So we go to where people are at. And I think that's one of the unique features of broadening who's considered a primary care provider to include nurses, is frankly that we do have somewhat of a different lens. It does deal with illness, disease really, diagnosis and treatment, but it's also how do people live with that illness? And that's part of our science, and health promotion and health maintenance and care coordination is something we have had a long history of performing.
You're a nurse practitioner, James. You're nodding your head. What are you thinking? Is there more that you feel like you could be doing that you're not allowed to do? Or what?
Certainly. I mean, there are obviously tremendous restrictions on nurse practitioners and on physician assistants throughout the country. Missouri is one of the poorest states when it comes to the scope of practice of things that we're allowed to do, the autonomy we're allowed to hold. Part of the coordination of care, I think, that Dr. Miller's talking about is very important. If she could hand off a patient with severe and complex chronic illness that just needs management, weekly, monthly, every 3 months, that's a tremendous effort, because if we could bring that patient back into the office, monitor them, make sure that, for instance, that their A1C is not every 3 months going crazy if they're a diabetic, then we can adjust those things. And in the long run, the cost will be lowered for that patient and the outcome will be improved because we're managing them and monitoring them more closely, and through the health literacy, they have a better hold on their understanding of the condition. So whether it's between a physician and a nurse practitioner or between two nurse practitioners, that coordination of care is critical.
He's kind of going to the solution area. What other solutions should we be looking at?
Yeah, there's a number of them. To bring it back to Obamacare and the impact, Obamacare is based on kind of what Massachusetts did in 2006. And we know from watching Massachusetts over the last several years that the need and the demand for primary care went up dramatically. They didn't have enough physicians. They couldn't get people in. They had a real problem with that. And so we're not going to be able to graduate enough people from medical school fast enough to do this. We absolutely need what's being talked about now. We need team care. We need Mike to get on the ball and turn out some more nurse practitioners for us. And we need to develop teams of people who are integrated and will work together to allow for that capacity. So we can get high quality, we can keep the costs down, but people actually get better care.
Okay.